Thank you. I'm going to introduce the next speaker. Is Dr. Kwang-Yu, actually from associate investigator from NHRI, with a joint appointment as associate professor in Chang University. She got the MD. She's a physician scientist. Got his MD from Kaohsiung Medical School, and after that, went to actually get a PhD in the National Chang University. Before she came to assistant professor position, she also spent 2 years in Johns Hopkins as a postdoc. So today she's going to talk about his effort using next generation sequencing to identify regional enriched mutational signature in Taiwan, different parts of Taiwan. Okay, thank you.
Thank you, everybody. So I want to say that I'm very pleasure. It is my pleasure to be right over here and talk about the study results in the past few years. And normally I am a molecular guy, but today my mission is to present something that is from clinical side. So I'm a little bit nervous. So especially because what I'm going to talk have a lot of overlap with the molecular field by Dr. Deng. Yeah, so I hope if there's any suggestion, I could get some suggestion for all of you. Okay, so today my topic title is the Taiwanese registry-based cohort study of urological cancer revealed a regionally enriched mutational signature in upper tract urothelial carcinoma. So first, from the background, a couple of years ago, TCOG decided to make a grand proposal to learn the oncogene mutation in multiple cancer types. And these cancer types, they have some features that is unique in Taiwan. And one of the cancer types is actually urothelial carcinoma and RCC, because even worldwide, it is really related to the geographic factors. And in Taiwan, we know that there's a high incidence of urothelial carcinoma, particularly the UTUC, which is upper tract urothelial carcinoma. So I guess the incidence, the annual incidence is 3 to 4 in 100,000 patients, so 100,000 patients, so 100,000 population. So I guess it is much more than the other side of area in the world. And because of these features, so in the past, there's a lot of studies and trying to find the carcinogen that is related to this UTUC. And one of the famous one is actually the AA, which is in cosmic signature SBS22. And in fact, it is associated with UC, RCC, and HCC, and intrahepatic cholangiocarcinoma. So because of this effort, AA containing substance has been prohibited in 2003 in Taiwan. So 20 years after this prohibition strategy policy, I mean, we were interested in whether our UC is still related to the AA signature. And this is because we still find a lot of urothelial carcinoma, and particularly the incidence of UTUC remains high. So while we use the NGS strategies to learn the genomic profile, it can give us some advantage, including to provide some precision medicine, and then deepens our understanding of the disease. And also, because of this advancement of and understanding of this tumor panel NGS, so we also know that it is capable of detecting cosmic signature, including the AA signature here. So we connected 9 medical hospitals in Taiwan, and there's 5 from Northern Taiwan and 4 from Southern Taiwan. And from 2023 to 2024, in 2 years, we had we had 591 samples sent to the ACT Genomics for the NGS profiles, and including 379 of urothelial carcinoma and 212 of renal cell carcinoma. And then for the geographic distribution, we found, okay, I guess this is good enough? Nope. It's a little bit too sensitive. Yeah. Okay. Okay. Too sensitive. Well, I'll try my best to control this stuff. Okay, so right now we have 379 urothelial carcinoma and 212 renal cell carcinoma, and the ratio between southern and northern samples is actually 3:1 for UC and 1:2 for RCC, which we found out that the UC is very prevalent in southern Taiwan. So these are the demography of the disease, the patient, and we know that it is very typical. For example, the gender, we can find there's more female gender comparing to male for the UTUC, including ureter cancer and renal pelvic cancer. But the opposite, we found higher male population than female for bladder cancer and RCC. And traditionally, UTUC is also associated with impaired renal function, and this is reflected over here. And also, we can find the stage distribution very evenly between from 1 to 4 stage. And for the pathology profiles, we found most UC is infiltrating urothelial carcinoma, and almost all RCC is pure clear cell type. And there's more diversity in NCC, RCC, but we can also find the higher percentage of papillary type and chromophobe type. And almost all of the cancer were in high grade. So now we go into the NGS profile, and first of all, we go through the RCC and find out that the very typical appearance. For example, in the morning, we just talked about VHL, PBRBM1, and also BAP1 in CCRCC, and this is very typical because it is related to the mutation in chromosome 3P. And for NCC, RCC, we can find there's more diversity. But generally speaking, we can find that there's a more chromosome loss in chromophobe type RCC, and there's more chromosome gain for papillary type RCC. So things go interesting in UC when we see there's actually some different features between the subset. For example, in ureter cancer, we can find a very much mutation in KMT2D, which is very different to bladder cancer and renal pelvic cancer. And then for the pan-UTUC, we can also find a higher incidence of RAS mutation and FGFR3 mutation in UTUC comparing to the bladder cancer. But for specifically for renal pelvic cancer, we found out there's a higher mutation load comparing to the other subset, for example, ureter or bladder cancer. And together, this urothelial carcinoma has a higher mutation load comparing to RCC. And interestingly, because nowadays we were always asking how about the tumor mutation burden, TMB. So for those tumor mutation high, we have the criteria, both from ACT Genomics criteria, that is 7.5, and then Foundation 1 criteria, which we are more familiar with, that is 10. And no matter which one, we can also find the higher TMB high population in renal pelvic carcinoma cancer comparing to the other ureter or bladder cancer. So now to the signature, the cosmic signature. We saw a very typical SBS2 and SBS13, which were known as apobex signature, very much expressed in bladder cancer. But for our interest, of course, it is SBS22, which is AA signature, and we found very high proportion, that is up to 30 to 40% in ureter cancer and renal pelvic cancer. So this makes the UTUC different comparing to the bladder or RCC. And while we still find some AA signature in bladder cancer and RCC, it is much less, only for 10%. So we try to correlate, associate this AA signature to the tumor mutation load, and find out that in AA signature harboring cancer, we can find about 65% of this disease showing TMB high features. Comparing to apobec, we can find there's no significance when we analyze the apobec or apobec negative cancers. And then if we rank the mutation load and by subset, and we found out that in the type that it has, that is TMB high criteria, we can find about 70 to 80% harboring SBS22 signature. Comparing to the bladder cancer, that's only 30%. So this makes A signature very specific, very signature to UTUC group. So now for the geographic factors, we found that for the tumor mutation burden load, tumor mutation loading, the southern Taiwan had higher mutation load compared to the northern Taiwan. And not only RUC, but particularly in renal pelvic, we see the statistical difference. And then for the AA prevalence in UC, we found in UTUC, the southern Taiwan had more cases showing the AA signature comparing to the northern Taiwan. So interestingly, we found that SBA22 fraction had a positive correlation to the tumor mutation load, particularly in UTUC, both in northern or southern Taiwan. And finally, we try to find out for those cancers, for those tissues that have no A signature, what makes it the tumor mutation burden high? And we found that apobec signature could have the role here in showing that the higher mutation load in the apobec signature comparing to the others, particularly in the bladder cancer. So I guess the database, the value of the database is actually we can correlate to the clinical finding, clinical implication. So we next try to learn what we can see from this survival data, and find out that the beta survival for the UTUC in Taiwan comparing to bladder cancer, and no matter it is TMB factor or AA signature, they both can have the differentiating role for the survival differences. However, not the apobec signature. But this is not the only thing we were concerned of. We also like to ask if how does the common systemic treatment perform in Taiwan for UC, and how does the genetic features alter the treatment efficacy. But from our retrospective study, we found out there's a lot of problem, including that there's a selective bias. So, and then also we found that the treatment for UC right now is actually very diverse. For example, we have dental treatment by chemotherapy followed by IO and ADC of EV. However, there's more and more clinical trials that brings EV to the front line. Or also, there is also some problem in the cases that have met criteria for insurance reimbursement in IO. So they have no chance to use IO for their whole life. So this is why we try to set a better endpoint for us. For a more robust study. And so let me first explain. We state the duration of treatment, DOT of a certain treatment. Also, we can go through the survival of a certain treatment and also the survival of the disease course. And this is an example. We show that with the DOT, duration of treatment of the first-line chemotherapy, the curve shows like this, and the EV and enfortumab vedotin, the curve shows like this, and the IOs, the curve shows like this. But of these drugs, we are most interested in IO. So because of the TMB was always linked to the effect of the IO. So we found out that in the performance of IO by defining the TMB high or low, we can differentiate the DOT of these patients, particularly in upper tract UC, which achieved the statistical differentiation. And interestingly, it has more power compared to the PD-L1, which is our standard using this PD-L1 criteria to apply the IO drug. And on the other hand, we also found that TMB criteria is not power enough to predict the DOT of chemotherapy or EV, which is not surprising because it has nothing to do with these two categories of drugs. And then we try to see the survival impact of IOs of the TMB and the signatures in IO, and found out that with the TMB criteria, we are able to differentiate the survival of IOs after IOs, and then also the AA signature was able to have this trend too, but particularly with integration of ApoBec signature, it makes a statistical difference in it. And interestingly, we also found that this TMB and AA ApoBec signature also have the trend over the salvage chemotherapy. So probably they have the IO effect in it. So finally, we used a linear regression with IO results and find out that the tumor mutation loading have the impact to the DOT of the IO. And then the SBS22 fraction have the impact to the survival of the IOs. So that our study, and we found out that after 20 years of the ban policy over the AA substance, we still find a lot of urothelial carcinoma that is related, that is harboring SBS22 signature. Well, this is not very surprising at all because in 2007, we already have the paper of HCC made by Dr. Zheng showing that there's still a associated HCC, which is not declined immediately, followed by the reduced AA exposure. And then the limitation, however, of our study is actually with even with the high signature shown in our tissue, we cannot make any conclusion for the role of SBS22 in our study. So so that means that whether this is a cause to the high UTUC incidence, we cannot make this conclusion. And partially it is because of the limited comprehensivity by NGS tumor panel we use. But on the other hand, we found out the similar study in esophageal cancer and head and neck cancer, which is led by my colleague. They did not find only a very extremely low SBS22 signature in esophageal cancer and head and neck cancer, which show that our study should be reliable. And from the past study, we also found out that the association of this high mutation load to HBS22 might affect some oncogene, making this disease very special in some certain unique oncogene. For example, KDM6A was rarely reported in the UTUC in the other place of the world. So I guess the reliability of this study, it actually makes me comfortable because we found out that in the UTUC, the genetic features is compatible to the others. For example, FGFR3 and RAS mutation shows higher incidence comparing to the bladder cancer, which is also known in the Japanese study in Cancer Cell 2021. And also the hypermutation subclass has better survival profile. So we can suggest that TMB high we found in our tissue probably can have support that IO to be the standard treatment of UC, because UC is among the malignancy in which IO response correlates with TMB, and this was known in from 2017. And moreover, recent data also show that TMB outperformed PD-L1 IHC in predicting response of IO in some clinical trials. Of course, this is their post-hoc study, but we still think this is really good for us to know the value. And since we know that TMB has this value in predicting IO, but how about the signature? So for the genetic signature, we already know that ApoBec signature can have the better prognosis for pembrolizumab use. However, we don't have the direct evidence for a signature, but from some indirect evidence, we can tell that in RCC, for example, in RCC, the A signature yielded more inflammatory genes, harbors more inflammatory genes in it. And then also in UTUC study, A signature was associated with enhanced immunity. So finally, to the conclusion, I would say this is the largest UC and RCC cohort for the NGS study in Taiwan. The genetic traits of UTUC showed a unique group of UC in Taiwan and was already reported in EAU by our leading investigator, Professor Zha Dailong. And then geographic factors had impact in the genetic appearance of UC, despite of long-standing ban on A containing traditional medicine. We still observe this important genetic characteristics. And finally, high proportion of TMB high disease could suggest a favorable treatment result. So early use of IOs upon precision recognition of the genetic tract would help the treatment in this population. So I want to thank all the investigators in this study, and also the leading investigator by Dr. Zha Dailong, and also the TCOG staff and the AI Center of NHI, which helped us to analyze the data. And I have to say, like MD always say, we always have trouble trying to find the meeting time. So finally, we use the online meeting. And then even with online meeting, we can only find the office time. So it is very tough for everybody. So I'm very grateful for having this study complete. And we are now trying to make the best from this study. Thank you so much.
Thank you, Dr. Zhang, for your great presentation. Any question for Dr. Zhang?
So we first published the UTUC. I think you cite the Hopkins paper. Actually, ours is in front of them. It's back to back. But if you look at that mutations, the UTUC, interesting that the genes are the same. The KDM6, P53, and etc. But if you look at liver, compare liver, the liver one is always A to T, T to A. But for kidney, for whatever reason, the VHL mutations and also for the UTUC, they're not quite A to T, T to A, which is still, to me, is still puzzling, because supposedly it's to be A to T, T to A. In liver is definitely the case, but in the UTUC and even the RCC, they're not the A to T, T to A, but they are driver mutations. So I wonder there are other chromosome changes or genetic that contribute to that. Still, yeah. I don't know whether you check the type of mutation. I mean, I know the genes are the same, but the actual mutation is whether it's C to G or A to T or T to A.
Yeah, I guess it is important to see if in the oncogen we can still find the the feature of SBS22. We haven't go to that step yet, but what I want to say is that in the previous past study, there's still a lot of studies showing that the AA signature can affect these oncogen, driver oncogens. So probably we expect that in the future we can reach this conclusion by more advanced analysis.
I mean, the other thing is that now the 22 is divided into A and B. Yeah, you should look at that also. I think in Taiwan, B is very uncommon. Yeah, it's the A.
You're talking about S22B. There's only one. Only one. So really, really uncommon. Yeah.
So I have a question. What do you speculate is a regional difference in the mutational signature? I assume your regional mean the hospital by which the sample were collected. Have you looked at this patient, do they grow up or walk in the south versus north? Instead of the hostile base, do they actually, where they come from, how long they were? Given such a small island and then people move around all over, what are the source of the variation?
Well, I guess there's still some difference between this, let's not say region, but northern or southern part of Taiwan, because no matter when we, every time when we talk about the difference, we always refer to something like education and their habit, and a lot of lifestyle difference. So I'm not, because I'm always I'm always grown up in South Taiwan. So what I know is that in Southern Taiwan, sometimes we like to say, oh, do you want to try Chinese herb instead of getting the standard medical treatment? Because the Chinese herb sounds like more easy to take comparing to the standard medical treatment. So I guess there's some lifestyle difference and the education's difference between these two parts. And also because our government was located in Northern Taiwan, so the policy could be more strict in Northern Taiwan, but not in Southern Taiwan.
This has nothing to do with the environment. It's related to how open you are to trying this, some of AA contained medicine, something like that.
Yeah, and probably environment may be another issue, but it is not what we are talking today, because from our data, we can only see the signature, but we don't know what makes the signature appears. The only direct connection is actually AA.
Any more questions for Dr. Chang? Okay, so we'll take a short coffee break before the last session about RAS. Thank you.